Welcome, everyone. My name is Therese Stone with the McKenzie Foundation Community Relations Committee. I'll be serving as the moderator for today's town hall event. We're holding these events for our community members, and we are really glad to have you with us today. I'll start by introducing each of our panelists. For today, we have Dr. Mark Hammond, who's McKenzie's Emergency Department Medical Director. We have Steve Barnett, who is McKenzie's President and CEO. Bryant Wilke, the Health Officer and Director of Environmental Health from Sanilac County Health Department. And Dr. Mark English, a McKenzie physician. So some housekeeping items for today. Your audio is automatically muted. We'd like you to use the Q&A function at the bottom of your screen to ask questions. Our town hall is going to be recorded and a link will be sent to you in a follow-up email. So our agenda is going to be the COVID-19 updates for our community, vaccine progress and scheduling, long COVID-19, and question and answer period. So today we're going to start off with Dr. Hammond.
Hi, everybody. Good morning, afternoon, and thanks for joining. So October 2021, we came a long way since last year in regards to, we have a few updates for the community. So now we have effective vaccines currently for ages 12 and up. We have boosters for populations 18 and over with certain chronic conditions, and also age 65 and older. And this is for the Pfizer booster. Now the FDA is going to be meeting next week to talk about the Moderna booster and possibly a Johnson & Johnson booster as well. So those are in the works for October 15th and 16th respectively. So there could be a decision on whether or not to get those boosters by the end of next week, which would be a really big help for the community. There's also discussion being held end of the month for a Pfizer vaccine for ages 5 to 11. The FDA is going to review that information from Pfizer and make a decision whether or not to approve or not the vaccine. And then that would be probably implemented very soon afterwards as well. Now, as far as therapeutics for COVID, we have a few new things that are on the map now. So if you remember before, we talked about monoclonal antibodies. We called it BAM. Now we call it MAB because there's so many different ones right now, MAB, MAB. The one that we're hearing more about is called Regeneron. So it's what President Trump got when he was sick with COVID last year. And what this does, the monoclonal antibody, for those who, so how it worked before, if you tested positive for COVID, were within about a week of symptoms, you could go to your local hospital, actually probably call to make an appointment for an infusion of this medication, which takes about an hour and a half to 2 hours. And what it does, it gives your body a big boost of these antibodies, about a 2 to 3 week supply of antibodies to help fight against the worst effects of COVID initially. Now, in the meantime, while your body's getting these artificial antibodies called monoclonal antibodies, your body's actually making its own antibodies to help protect against COVID for the long term. So what's different now is that previously, when it was only for those who tested positive for COVID, now it's actually approved for those who are exposed to COVID and are of a high risk category condition, such as certain age requirements, chronic conditions, immunosuppressed. So we're going to probably be seeing more of those, would probably be more applicable to people who are in constant contact with those who are positive, such as household residents, jailmates, nursing home roommates. So it's a very broad category of people who would be eligible for it's what we call a post-exposure prophylactic. So more of a preventative medication to help prevent against getting COVID. So with this, you don't even need a positive test. You just need to be of that high-risk category and have met that condition called the close contact criteria. That would be enough to say, hey, doc, or talk to your healthcare provider about getting an order for that medication. And again, it's on an appointment basis only. And it's been shown to reduce the chance of death due to COVID by 80%, which is amazing. And in addition to therapeutics, we also have remdesivir, which is in the hospital. We also have what we know for people in the hospital sick with COVID is certain steroids and other medications to help prevent how sick you can get. And there is even discussion now. Merck, the company, released information about a possible pill for COVID. What this would do. So again, I just wanted to take a step back and say this is information from the drug company, not reviewed by FDA, not FDA sanctioned. It's just what the company released. At least it's a pill to help people who've been infected with COVID. It would help shorten the duration of sickness and also help minimize how sick they can get with COVID. This would work almost the same way as a medication called Tamiflu, which we get for influenza currently. Again, this is still far out. The FDA still hasn't reviewed it yet, but if it is approved, it could be a game changer. But let's be very clear about this. Nothing beats a vaccine. Nothing beats having immunity against COVID. Our county percent positivity rate, I was told this morning, is 15%. It's very high, very high. So we're in a high transmission rate right now. We've had multiple people become reinfected with COVID who've had COVID back in June. So 4 months. So we're seeing people who've been infected with COVID previously are becoming infected again as soon as 4 months later. So I know I had this big hope for natural immunity being a slam dunk, but it's not. What proved to have longer immunity are the vaccines. And this is, I don't want to say a gamble to think you get COVID, you're gonna be fine. No, but we see those who've been infected with COVID and who had really bad symptoms, like really bad symptoms, maybe need to go to the hospital, they might have developed longer lasting antibodies than those with mild COVID. So again, don't be fooled by the fact that you had COVID and you're gonna be fine for, a number of months. The magic number might be about 3 months. And we're seeing that, kind of work itself out right now too. And locally, at least, we're seeing within 4 months, we're seeing people getting sick again with COVID. So if you have COVID, get vaccinated. If you've been vaccinated, get your booster shot. Kids that get COVID will generally be fine. However, kids are spreading this to adults. And we're seeing a lot of household transmissions that way too. As we're seeing multi-generational households. So a kid goes to school, gets exposed to COVID, comes home, passes to grandma, grandpa, aunt, uncle, cousin, and they're the ones becoming very sick with this. Dr. English will talk more about the long-term effects of COVID, called long COVID, which kids can get. 15% of kids, if not more than that, who get COVID are at risk of getting long COVID, not to mention what they call multi-system inflammatory disease of children, which is MISC, which is something that kids who've had COVID can develop weeks to months later. It's like a body attacking itself in the inflammatory process. We could talk more about that at a different time, but definitely something on our radar where, people just have to be careful about getting COVID and also the long-term ramifications of what getting COVID means too. And with that, I'll pass on to Steve.
Well, thank you, Dr. Hammett. I appreciate it. As always, you give us a lot of insight as to what's going on, both nationally and globally. And what I'm going to try and address real quickly is what we're doing testing-wise at McKenzie. As we had been doing in the past with PCR testing, we continue to do that. The problem now, though, is that we are running up against a supply issue. So we have the capacity to do the testing, and we can do a lot of it. We've added 2 more instruments, but we can't get the supplies. And this is in part due to what we see going on nationally. And there's been an increase in testing across the country, along with, as most people know, what we call a high transmission rate. So we see when we look at the United States and we look at Michigan, we're all red, which means that we're at that level of transmission. And a lot of this is due to how contagious the Delta variant is of COVID. And what we are finding is that those tests that we do send off to have that Delta variant analyzed, 99% of them are coming back as being positive with the Delta variant. So it's just contributing to this cycle of high transmission, which speaks to why we're so eager to see the percentage of the population increase in terms of being vaccinated. So if you're coming in to be tested at McKenzie. If we cannot run it because of a supply issue here, we may send it out to a reference lab. And all that means to you is that it's going to take a little longer to get the results back than what we might have been able to do internally, but we will get those results back for you as quickly as possible. What we are seeing is many of the people that are coming in to have the testing done are really doing it for travel reasons or return to work. So at least we're not seeing a significant spike in people that are coming in because they're symptomatic. In terms of everyone knowing somebody who's had a vaccine but became COVID positive, when you look at the larger database, that percentage, even though it seems like it's high, is more anecdotally high. Really is probably less than what we've seen with flu vaccines in the past in terms of people having the flu after they've been vaccinated. So I wouldn't put a lot of stock in that being a reason not to become vaccinated if you have an opportunity or you're leaning in the direction to do that. The last thing that I would like to point out is that there's been a lot of talk about the Biden administration issuing a requirement for vaccination, and that is segregated into really two groups of employees. And one is employers who have more than 100 employees. They would be required to have those employees vaccinated or test them every week. And that will be governed by OSHA. And so OSHA is the federal governing body, and that at a state level, it's my OSHA, and they can tighten up those regs that OSHA might have, but basically the two will function together. One can't do something that the federal government is asking us to do. They can only make it a little tighter. Then the other group are healthcare, those folks that work in hospitals. And there won't be an option for weekly testing. It'll be vaccination. Many know that many of the healthcare systems that have a presence in Michigan, Henry Ford, for example, were really first out of the block to require their employees to be vaccinated, followed by Trinity, Ascension, Beaumont, and others around the state. So this is not something that we're driving at a local level or state or even national level. It's not something that we want to engage in, and that is requiring, but it's outside of our control. The way it's managed for healthcare personnel is if you're a hospital who accepts payment from Medicare for Medicare patients and Medicaid, then because you accept that payment and those payers are federal and state, they can make that a requirement of payment, and it's called a condition of participation. We cannot afford to lose that payer, that population, and we don't want to fall out of compliance with those regulations. So remains to be seen how this is going to play itself out, but we hope to see a little bit more clarity on that issue, which I know a lot of people are becoming a little bit anxious about, but it's not clear yet. But I hope within the next couple of weeks, we'll see additional clarity and some sort of timeline that's going to be used to govern and regulate this. So having said all that, if there are questions, we'll take them at the end, but I'd like to hand it off to our Executive Director for Sanilac County Health Department, Bryant Wilke.
Thank you, Steve, and thank you for the concise update on McKenzie's operations. So, I kind of get into the statistics right away a little bit to complement what Doc Hammond had talked about, as well as Steve. But in the state of Michigan, we're over a million cases, confirmed cases with COVID. Along with that, unfortunately, we've seen 21,139 as of today deaths within the state of Michigan itself. Here in Sanilac County, we've had 4,039 confirmed cases with 123 deaths. Doc Hammond mentioned our percentage of positives. In September, we had a total of 205 cases, and just reported out today by Michelle McDonald, our communicable disease nurse, we have 91 cases in October in the last 6 days. Last 2 weeks, 2 weeks ago, we had 7% positivity rate, and we're already at 15%. So just to emphasize that we're seeing a spike in the transmissivity with throughout the county. So it's very important that we start paying attention to this. From my last report too, because a lot of people ask us, well, how many people are hospitalized? And sometimes it's difficult for us to tell you coming out of Sanilac County. But statewide, there's 45 PEDS cases that are in the hospital, and that's 18 or younger. So we're seeing this Delta variant really across the board on age brackets. So we're seeing a lot more young children coming down with COVID-19. It's very important to think about that as our schools are operating and we're trying to get along in normal life as we can. But this the Delta variant is disrupting some things, and it can unfortunately cause more disruptions if we don't get a handle on it. And you know, the main thing that we really want people to think about and consider, of course, is the vaccinations for those age brackets that are acceptable. And in that regard, Michigan stands around 63.7%. So we're getting closer and closer each day to that 70 percentile where we'd like to see us. However, in Sanilac County, we stand at 49.1%, just close to that 50% mark, which would be nice to get to. You can always, we're open for vaccination scheduling at the health department by going to our website or calling the number at our website. Easy to be done. Just make that appointment. And I know there's been a lot of confusion on the boosters, so I want everybody to know we do have the booster shots if you did have Pfizer in the past. And those who should get that shot are 65 years old and older. If you're a resident of a care facility, you should get that shot. And if you have an underlying medical condition, you should get that shot. Now, the current standard is also you may get the shot, the booster shot, if you're 18 or 49 years old with any underlying conditions. And if you're at a high-risk job, whether it's medical or essential worker, I should say too, it doesn't have to be necessarily high risk. So your grocery counter people, your food service people, all those essential workers that we've talked about in the past, you are eligible for that booster shot. Pfizer only at this point, like Dr. Hammett pointed out. And it is, oh, I lost my thought there. 6 months after your second dose of Pfizer. Is that correct, Dr. Hammett? 6 months, yes. So he's shaking his head, yes. So with that, that's kind of a little bit of update what's happening. And we really encourage those that haven't gotten the vaccine to think about it, encourage your friends and family members. And when you're out and about, if you're in close contact in a grocery store or any type of setting like that with people that you're not familiar with, we still suggest distancing and wearing a mask. So with that, I think we have our anchor today is Dr. Mark English. So I'll hand it over to Dr. English.
Thank you. Thank you, Brian. Ladies and gentlemen, COVID as an infection, as we all know, is ravaging the country at this time. And the mass majority of people who get infected with COVID will probably have what we call a subclinical or a mild infection, respiratory symptoms. But that's not true for not everybody. A great many people will go on to have a more serious infection that will probably keep them very sick for a couple of weeks to the point of hospitalization in some cases and possible death and winding up in the intensive care unit. Having said that, the vast majority of people will somehow recover to some level of functionality. Unfortunately, some folks will be carrying on, as the old saying goes, long after the music's over, the melody lingers on. And this is what we call a long hauler. Well, for many cases, it'll take 3 to 4 weeks for you to recover from COVID if you've had a moderate to serious infection. But afterwards, patients tend to still have problems that go on. Shortness of breath, lightheadedness, dizziness, brain fog, weakness, and other underlying medical conditions that have been worsened by the COVID virus itself. And this is now known as the long hauler syndrome. Long hauler or post-COVID syndrome refers to patients who have those symptoms I just mentioned. If so, you need to follow up with your primary care provider if you're not getting any better. That goes without saying. At that point, your doctor or provider should be looking at you carefully, decide, is this an underlying medical condition that existed before that has gotten worse, or is there something else going on? Some of the long hauler symptoms, let us start with one of the most common, is loss of smell and taste. Now, this is probably because the virus, being a respiratory virus, attacks the respiratory tract at its origin, the mouth and the nose, specifically in the sinus passages. The virus attacks the mucosa of the nose, the mucous membranes of the nose, and the only place in the body where the nervous system has direct contact with the outside environment. Nerve cells actually are in the upper part of the nasal passages, and they are affected by the virus. This swelling and inflammation decreases their function and actually damages them. But there is some hope. It seems that in most cases, many of the patients recover most of their sense of smell within a month or two after the infection. This is because some of that tissue is highly resilient and regenerative. Some patients, it takes even longer. In fact, in some cases, they're recommending recovery may not completely recover and for about a year in many cases. This does have effects on how we perceive food, how we eat, things we taste, and this could affect how we eat, the nutrition that we're taking in, and that could have long-term effects on us. Next, the next place in the body that's affected is the respiratory tract, down into the lungs. The virus breaks into the lungs and damages lung tissue by causing pneumonia, causing inflammation in the airways, causing fluid to fill up the air spaces where oxygen exchange takes place, and therefore leads to the respiratory scarring and damaging of the lung tissue. It may take months for those lungs to recover, if at all. And if so, basically, you're going to have other problems because once it broke through the air exchange areas in the lungs, the alveoli, it makes its way into the circulation and spreads to the rest of the body. Into the heart, which also causes, the virus causes problems with heart muscle. This is called myocarditis. And also into the kidneys and causing kidney failure in some folks. The thing is, basically, all these have an additive effect throughout the body. And a syndrome has developed called POTS. Postural, orthostatic, tachycardic syndrome, which means when you stand up, your blood pressure drops and your heart rate becomes very rapid, meaning you're getting decreased blood flow to other organs such as the brain, the heart, throughout the whole body. And this can also lead to further damage and injury. This happens with other symptoms too, and other disease states when patients have heart attacks, heart failure, etc. But this is long lasting. This may be due to the post-inflammatory aspect of the virus spreading throughout the body. As I said, long after the music's over, the melody lingers on. In other words, the virus may still be hanging around in some form or another in tissues in the body, and your immune system is attacking it still as foreign. We have seen similar things like this in the past with other viruses. There's a syndrome for folks called idiopathic dilated cardiomyopathy. The current theory for that is that a respiratory virus infects a person and it affects the heart muscle, and the body's immune system sees it as foreign and attacks the heart muscle. It isn't common, it doesn't happen often, but it does happen. It can happen to young people and to older people. Something similar to this may be happening with COVID at this time. Only because COVID is much more, shall we say, virulent. It can attack a lot faster and a lot harder and do a lot more damage. The thing you need to know is that if you have symptoms of shortness of breath, lightheadedness, dizziness, 1 to 2 months after the fact, you need to see your family physician or provider. They need to evaluate you. You might need to have an echocardiogram. You might need to have a chest x-ray. You may need to have a CAT scan of the lungs to see, do you have pulmonary emboli? These are blood clots that form because of the virus infecting you and your circulation. And then you shower these small blood clots throughout the body into the circulation. They make their way into the lungs, plugging up the blood vessels in the lungs, and this decreases oxygen exchange even further, which could be deadly in some cases. What you need to know is that if this is so, then you need to be treated appropriately. Sometimes blood thinners may be required to allow the lungs a chance to recover, allow the circulatory system to recover. This is not just happening to elderly people or people who have just happened to have diabetes or underlying histories of kidney disease, heart disease, or chronic lung disease. This is happening to young and healthy people. We've heard stories now where young people who are athletic, even personal trainers, months after the fact, can't even walk up a flight of stairs without becoming exhausted. And now I'm not talking a large flight of stairs, I'm talking 5 or 6 steps. This is a case whereby you need to be diagnosed early so you can receive treatment early so you can prevent the long-term complications and also safeguard your health. With that, I'll open the door to any questions. Mark?
Okay, so it is time for our question and answer period. And it sounds like Dr. Hammond has a question already for us.
Dr. English, hey. So what's your recommendation, Dr. English, about when somebody does have COVID, how soon should they follow up with their primary care provider before they go back to work or activities for them?
As soon as they are able to come out of quarantine, as long as they're able to, they should see their family physician after they've quarantined to see if there's any problems then, and it should be followed up maybe a few weeks, maybe a month later to see if those problems are resolving. If they're not, further studies should be done, an evaluation should be done of those people. The longer you wait, the more likely that the problem is going to happen. Another thing I would like to add to what I said earlier, there is a way to prevent long hauler syndrome. I know this sounds kind of trite, but here it is. Don't get COVID. That maintains that you wear a mask, social distance, avoid people who might be infected, avoid situations where you might get infected, and get vaccinated.
Hey, just a quick reminder, if those of you who are participating, you can enter any questions that you might have in the Q&A down at the bottom of your screen. So just a reminder about that. I have one question already, and I think it's for either Dr. Hammond or Dr. English. So I have some elderly relatives and they were asking about getting their flu shot and also getting their COVID third booster shot or their booster shot. So they were wondering, should they get that? Should they space those 2 shots out? And which one would you suggest should be first?
Frankly, I would recommend right now, as soon as you can, get your influenza vaccine. If you're less than 6 months out, then wait for the COVID vaccine. But I would definitely recommend getting influenza vaccine early this year. Last year, a great many people got their vaccines for influenza early on. And also because of the lack of social activities and social distancing to some degree and wearing masks, influenza infections and illness and hospitalizations were down 98% nationwide.
Yep, and I think they are recommending now that you can actually get the COVID vaccine in combination with other vaccines too. So the same day you go for your appointment, you could knock out your COVID shot.
Absolutely.
Okay, so no need to space those 2 out.
No. So initially the CDC did recommend it way back when they first offered the vaccines just to see. Now they're saying that they've been proven and safe to be given in combination with other vaccines too. So now the recommendation is to get them both at the same time. It's fine.
Thank you. Okay, so we do have a question from our viewers, our participants, and that is, when will the Moderna booster be available, do you think?
Mark, do you want to handle that?
Yeah, so the FDA is meeting next week to discuss that. So my guesses would be usually within 24 to 48 hours of approval is when it'd be available. Now, some people who've had other vaccines are getting another vaccine from somebody else or from somewhere else. They're mixing vaccines, which at this time the FDA is saying don't do it.
It's debatable.
But so wait for more information about that though. So definitely if you've had your previous vaccine with a certain the company, try to stick with that one too until otherwise by the FDA, please.
Okay, so our next question is related to Moderna. Asking if the third Moderna shot, is there a concern because it's a full dose of the vaccine, I guess?
Well, we don't know the dosing yet for it, so I'd hold off and wait to see for sure the FDA says, because again, what they do is they actually will review the information and then give the recommendations, and then they take it from there. So I'd be very reluctant to say what the dose would be. From what I'm hearing, though, it might be the same dose, but it might be less. So again, I know, and one thing too, I'll say about the process, FDA process, is it works beautifully too. So if you look at how they came to the conclusion about who to vaccinate during this last Pfizer booster, there was debate, and it was a good, healthy debate, because they kind of weighed out pros and cons for each age group and each kind of like risk condition. So the process works. Just put your trust in the process. The FDA will review it in detail and give the recommendations, and then you'll see it out in the public as soon as it's available. So.
I would agree with Mark on that. There's a great deal of conflicting research right now that they're going to have to wade through and look at the statistics on that. If you look back, why was the Pfizer vaccine determined to be considered for a booster? Well, look at the Israelis, who predominantly went with Pfizer as a nation. 65% of their population vaccinated, which is incredible in a short span of time. But they noted that in their studies, they looked at the protective effects from hospitalization, severe illness, and initially I think it was like 90% protection on the after the second vaccine, and about several months later it was down, I think, about 85%. So they were a little concerned about it waning. Most people should realize that most vaccines are considered protective at 70%, so that's still a good number. But they're right, they're concerned and they want to be protected. So yeah, they're looking at that. Moderna, on the other hand, in some of the studies that were done, showed that it was protective effect 1 month out after the second shot at 93%. And then 4 months later, at 120 days, it showed that its protective effect was like about 92%. So it still held. But I wouldn't bet the house on that just yet. So I would wait to see what the further research shows on that. The other one was the Johnson & Johnson vaccine. Some people did get a second vaccine, and their protective effect actually went up significantly. But again, we need to have more data before we make some far-reaching decisions on that.
And I'll tell you too, the question about, I think, the full dose for the Moderna, for any vaccine, really is a good question, because will there be side effects? The big thing is side effects. That turns a lot of people off. I'll tell you, after my first, so I had the Pfizer. I will admit I had Pfizer. Okay. My first dose, I had side effects. Great. The second dose, I was prepared. I had the day off of work the next day. I told my wife, honey, I'm going to get sick. Solid, nothing, no side effects at all. So I think it's very variable for each person. So I would always assume the next day or two, you might feel kind of crummy, regardless of whatever vaccine you get, whatever booster you get. But you might be surprised. Hopefully that's the case.
Okay, so we have some questions about the COVID long haulers. And Dr. English, are there people or groups who are at a higher risk of developing COVID long haul symptoms?
Yes, there are. Elderly, people with chronic lung disease, patients with diabetes, patients with history of heart disease, and people with kidney disease do seem to have much more severe illness. Also, people who have rheumatologic conditions seem to be more prone, especially like diseases such as lupus, because of vascular disease that they get with it.
Okay. So related to that, we have a question about what's the length of time you could expect those the long haul COVID to last?
No one knows for certain right now. They're still watching. We're only about a year into this a year and a half into this pandemic. It's going to be a while before we have any long-term conclusive numbers. In most cases, you're looking maybe 3 to 4 years after the fact. But what it's showing is basically that people are still months after that, even sometimes a year after the fact, still have weakness and debility with it.
I personally know a lot of people who develop what they call brain fog after getting COVID. Where they just are very forgetful about things and just really not their norm. And this is about 4 or 5 months after the fact too. So
there's something else to go with that. We should also talk about right now, because of patients being severely ill, disabled, at home, away from people, or in the ICUs and hospitals. There's going to be an undercurrent of severe depression in many cases and post-traumatic stress disorder. That's another problem we're going to have to be dealing with for a long time to come.
Does coronavirus create inflammation? And can you just talk a little bit about that how that affects the body.
The virus itself comes in and actually does what it does quite well. It joins and binds to cells in the lung and other parts of the body. The body's immune system initially sees it as foreign and goes after it. The usual first line of defense in most cases is cells, giant white blood cells called macrophages. They are there to modulate the immune response, and they also give the information to the lymphocytes in the body to make antibodies, interleukins, leukotrienes, to fight the virus, and also other white lymphocytes to make antibodies against it. In the initial phase, some folks get what we call cytokine storm, where they release a tremendous surge of immune proteins against the virus. Unfortunately, this also goes against the body's circulatory system, the linings of the blood vessels, and also throughout the whole other organs throughout the body. For instance, in the lungs and in the kidneys, when you get down to the actual functioning part of those organs, there's very small units within there with capillaries covering them. So the inflammation into the blood vessels goes right to the part of the organ that does the work. There's protein leakage, tissue damage, cell damage, and the inflammatory response the body does so well as a series of cascades, of chemical cascades, that one after another sets one off, and it starts forming inflammation in the walls, blood clot formation, etc. And this is what leads to most of the damage. Now imagine this making its way to the nervous system, especially the central nervous system, and also the peripheral nervous system, part of which is called the autonomic nervous system, which maintains your blood pressure, heart rate, etc. If they're short-circuited or damaged, you're going to have a lot of problems long-term with this. Some of that might regenerate, not all. And there's going to be long-term complications from this. As Mark said, brain fog. If it makes its way to the brain and damages large sections of the brain, the damage may be permanent in some cases.
Okay, so we have another question regarding testing for COVID will be billed to insurance and isn't free. So can anyone comment on that?
Yeah, when we can, we do send, bill the insurance company. Historically, they've been asked to pick up the cost of that. I don't know with the potential regs that are coming out. I think that's an unanswered question as to who's going to be paying for testing when you say are an employer group with over 100 employees.
Okay, thank you. We have another question about inflammation. How do you reduce inflammation related to COVID?
Good question. Mark mentioned some of them. One, the monoclonal antibodies are one, because they help defeat the purpose of the virus. Two, steroids in some cases have been shown to be beneficial, such as prednisone. Takes down inflammation in the tissues locally. Be careful using anti-inflammatories in people with kidney failure. It may worsen them, such as ibuprofen, naproxen. I'd be very careful. The only anti-inflammatory I would recommend for anybody who has COVID who might be set up for blood clots is 81 milligram strength aspirin to prevent some of the clotting factors. If clots still persist, then you maybe want to talk to your doctor about using one of the blood thinners such as Eliquis or Coumadin to prevent further clots from forming in the body. But as for the anti-inflammatory effect, they're usually now looking now pretty much at steroids and the antibody cocktails.
And I'll add on to there too, is one thing we're seeing too, when we talk about how COVID affects people, as Dr. English mentioned, those with chronic conditions are at highest risk. So it's only more of an incentive to take care of yourself. If you have chronic conditions, take your medications, talk to your healthcare provider, kind of optimize your health now. So if you do get COVID, you're really in the best shape possible to help fight against it too.
Thank you for that. Let's see, we have another question. Okay, this one asks, would an anti-inflammatory diet prevent future inflammatory complications? And this is the question the person's asking based on personal experience, they said.
That would be a very hard sell. Eating a healthy diet, keeping yourself healthy in general may be beneficial, but immune systems vary from person to person. It may not matter what you are eating. in some cases. It may just be a matter, you can have the most healthy individuals on the face of the earth, and they can have a hyperimmune response to the virus instead, and it may just be just the opposite effect. Yeah, I recommend a healthy diet for mostly everybody in my practice, to higher protein, cut down carbs and starches and processed sugars in their diet. Yes, I think that's beneficial in any situation. Smaller portions, more protein throughout, and even bursts throughout the day may help bolster your immune response long term, because most of your antibodies and cells are made of protein to begin with. Everybody says, well, I'll use mega doses of vitamin C. Vitamin C doesn't really bolster your immune cells. Okay, it bolsters the collagen matrix in your body, which makes up all the membranes in the body to prevent organisms from passing through. It may even help you reduce iron to bring more iron in your system, but there's no study that ever showed that it kills germs or helpful in killing germs. So be careful what you're taking, because even sometimes mega doses of nutrients and supplements may not be beneficial.
I think too, if you don't mind, what you're hearing from Dr. English and from Dr. Hammond as it relates to how the body functions and where the virus is effective, and all of the physiology that goes with this, it can be complicated. And I know a lot of people get frustrated because they don't understand medicine and they don't understand how the body works. And they think the more we talk about it and the more complicated it is, the more difficult it is to deal with, and they'd rather just look away. I think one of the simplest messages, though, if you want to back away from the deep dive on pathophysiology and medicine, is what Dr. English mentioned earlier, and that is last year, most people were not out and about. So they weren't exposed to others. And if they were wearing masks. And what we saw was a significant decline in flu. And I think the mask wearing and social distancing were the key factors that really tied to that decline that we saw last year. So, we're talking about how the impact of the virus can affect the body in the long haul, and that's all extremely important. And the more people understand it, the better off everyone is. But at the heart of all of this is if we would just accept the fact that we need to do some simple things like distance and wear a mask. And I mean wear a mask properly. I see it all the time where it's being worn over the mouth, but not over the nose. And I think you talked about where the virus resides. Why do you think we test, with a swab up the nose? Because, that's where it's sitting. So we need that mask to be worn properly. You might as well not wear it at all. So those simple things that we can do, I think, are being underscored by the deeper dive of what Dr. English and Dr. Hammond are talking about from a physiological standpoint.
But Teresa, I got to really jump on that, because it's so important that we think about what Steve's talking about, and Dr. English and Dr. Hammond, about the prevention side of this. And I know masking has become a really political issue, and we really need to drop our guard in regards to politics and protect ourselves by wearing a mask. I was out in the community this past weekend, and I was almost embarrassed, my wife and I, going into some stores that her and I were the only ones wearing masks with a few of the employees. And I'm like, what is going on with our, our community, and not only ours, but, throughout Michigan, that we're letting our guard down by this COVID-19 variant is really taking hold. So that's a strong message we got to get out there. Still provide those preventive measures, and that's masking and distancing. I'll leave it at that.
Thank you. I appreciate that. So just to clarify, I think this was addressed in the beginning, but just to clarify, so if you've received both of the Moderna vaccines, you probably shouldn't mix and match and get the Pfizer booster. Correct?
Correct.
Okay, and then how to schedule that booster shot? Bryant, they just call the health department if they're eligible?
There's two ways. You can go to our website, sanilachhealth.com, and there's actually a online scheduling program. You just go to the clinic that you'd like. It's a special link. Once you get to our website, just punch up vaccine. Or you can call, and I can give you that number. It's 810-207-0962 if you need assistance making that appointment.
Okay, thank you. Let me double check the Q&A again. I think we already answered that question. Okay, so we had another question about should aspirin be used for children who may be experiencing COVID symptoms?
No.
No.
Avoid aspirin.
No.
The kids avoid aspirin.
Okay,
It leads to a very rare condition called Ray's disease. You don't.
Ray's syndrome.
Yeah.
Yeah, in young children, I do not recommend aspirin at this time because Ray's syndrome is related to respiratory viral syndromes along with aspirin. In this situation, I don't think that would be a particularly good idea for them.
okay.
Make it take a bad situation, make it worse.
So I've heard a lot about natural immunity versus vaccine immunity. And I know, Dr. Hammond, you addressed that in your talk, but could you maybe just talk about that a little bit more, or Dr. English, whoever wants to jump in?
I think we have to be, we have to remember that people will develop natural immunity, but the magic question is how long does it last for? Nobody knows. Nobody knows reliably how long it lasts for. Now, nobody knows reliably how long a vaccine lasts for too, but we have data that shows that it lasts longer. It's more reliable than natural immunity too, because we talked about, from what we're hearing, at least from the data we're seeing, those who've been very sick with COVID end up getting longer lasting immunity.
Mm-hmm.
So yeah, you might have been exposed to COVID, you might have had COVID, a runny nose, and tested positive,
mm-hmm.
but that might be a false sense of security that you're good to go from now on. So we do know the 90-day window period is probably a reliable indicator, per what the CDC is even saying too. That's why you keep hearing about 90 days since this, that, because the data has shown that within 90 days, you probably have some kind of protection going on there. But locally, we're even seeing within 4 months of a previous infection, people getting infected again.
Yeah.
With the vaccines, we're seeing at least, I think on average, at least a 6 month to 8 month, if not longer, protection against severe hospitalizations. Reinfections, probably that time frame too. However, we have to remember the goal of vaccine wasn't to prevent a runny nose or a sinus infection. It was to prevent death and severe hospitalization from COVID. And it's doing its trick. The vast majority of people that we're seeing locally who need to be in hospital are unvaccinated. And this is common for the whole rest of the country too. Actually, the rest of the world. 17% of people in Israel, 17% of the hospitalized people, 17% of Israel's population over age 65 has not been vaccinated. They make up 80% of the hospitalizations in Israel. So that small amount of people in Israel who haven't been vaccinated make up 80% of those who are in the hospital with COVID now. So again, we follow what Israel is doing because Israel took the lead and really vaccinated their whole community, the majority of their community. So what they're seeing, it's probably what we'll be seeing too. And really, we just have to kind of, and this is a worldwide, a pandemic. So really, it's it came from somewhere else in the world to us. So we have to, just how we saw in COVID when the Delta variant affected Florida and Texas, and we were kind of hanging out in Michigan thinking we're going to be fine. We knew what could happen, and it's happening now to us locally too. So we have to keep all hands on deck at this point and really be mindful of what's going on.
And Dr. Hammond points out or used the word immunity several times, and we now can test for whether or not somebody has antibodies. And what everybody wants to know is, do they have immunity? And what I would caution anyone who's getting one of those tests at another lab someplace, or even getting it here, to recognize that we've not really settled on the unit of measure, and we don't know what the range means when we look at the number that's produced from that test. And we certainly don't know if it means that you have any kind of immunity. So most of the literature that comes with that testing speaks to that issue, that this is not in any way to be interpreted as you being immune, but it is interesting to look at the numbers that are coming back. And in some cases, people that are vaccinated are often well above, well, we don't know how far above, but we know that they're beyond the high end of the range, which suggests that they have a high number of antibodies that are present. Still doesn't mean that you're immune. It just means that you've got a lot. And then we see people who were never ill. They wanted to see if they have any antibody formation, and they're surprised to find that they are positive. They do have some, but the number of antibodies that they have are very low in that range. So if they were exposed, they must have been exposed. That natural response did not necessarily produce the same kind of antibody formation that we're seeing with the vaccine. And that's all that we can draw in terms of conclusions from the information that we're seeing right now. We hope with the research that's being done on quantitative analysis for antibody formation, we hope that eventually that's going to lead to drawing some conclusions about immunity, but we're not there yet.
To amplify what Steve just said, it's not just antibodies and the quantity of antibodies, it's the type of antibodies you're carrying. Classic example of this happened in Brazil last year. The alpha variant, the initial variant, went through Brazil, killing tens of thousands, hundreds of thousands of people. 5 months later, those populations that were infected who had recovered got a second wave of a virus, and it hit them, and it was a new variant. They got sick, and many of those people died. And the reason why was the scientists found out later on when they analyzed the viruses that the second virus had a change in the protein coat, in the spike proteins, and the antibodies did not recognize that any further. The thing about the Moderna and the Pfizer vaccines in particular is they're the genetics of the virus, not the protein coat, and the genetics doesn't change that much. So it may be comparing some of the protection. Again, we'll find out as time goes on. Sooner or later, the genetics too are going to change, and we may have to have other new vaccines for that. The idea is stay ahead of the game. Just remember, a great American once observed, an ounce of prevention is worth a ton of cure. And that was Ben Franklin. Sage wisdom from about 250 years ago.
Okay, so we do have another question here, and it's asking if that they've heard that some people have received a third Moderna shot at their pharmacy. I didn't think there was a third Moderna shot yet.
Yeah, so there's not really supposed to be a third Moderna shot yet. Here's what's happening. People are going to pharmacies, and actually any place that's supposed to give you your vaccine should be confirming your vaccination record.
Mm-hmm.
They can look it up on their MICR system and confirming that you actually need the dose you're saying you're going to get. So that's more of an operator error on their end of the pharmacy, or whoever's getting the shot. They should not be giving that shot out if it's a third. I could see it where people probably who got Moderna are going to get the booster shot of Pfizer, and that's not being verified, and it should be verified though. So absolutely a good question. And I heard case reports too. So really it's out there. It really is.
Yeah.
My recommendation is stick with FDA's guidance, get what you got before until they tell you otherwise, which they might tell us otherwise, but for now they're saying stick with the one you got previously.
Also, the initial recommendations for the booster was aimed at patients who were immune compromised to begin with, patients who had organ transplants, on immunosuppression, cancer patients on chemotherapy, because their immune systems aren't working as well as the rest of us, and they probably needed a booster. But that's an exception, not the rule.
Okay. I know that before we went live, I was asking Dr. English about ivermectin and maybe some of those other treatments that people talk about on social media. And maybe there seems to be a lot of misinformation out there. So if you would like to start us off, and anyone else can jump in on that.
On ivermectin, number one, was originally designed as an antimicrobial for parasitic infections, such as certain types of worms, or for lice or scabies, usually as a lotion. It could be used internally, but in small amounts, because it should have a profound effect on a parasite such as a worm. Strongyloides is the name of the worm, and it's in third world countries. What was ivermectin? The research that was done on it was done in tissue culture, in a cell culture, at 100 times the normal amount you would be needed for any human being. And then when one looks at the toxicities, neurotoxicity and nervous system toxicity and so on, I hardly recommend that at this time, especially in dealing with a virus. Molnupiravir, the new one that Merck has come out with, is under investigation, and it seems promising. It disrupts the genetic replication of the virus. And it's 4 pills twice a day for a specified period of time. The only problem is you have to be infected first to get it, and I don't think it's going to be recommended for certain patients. One in particular, one group may be pregnant women because of the potential for mutagenic. Although they don't say there is, they're going to hold off on that for now, from what I was reading in the literature. It's interesting and it's highly promising because the number of severe illness is, when compared to the placebo groups, were much lower, and there was no fatalities. The other interesting part about molnupiravir was that the placebo group, compared to the people actually taking the drug, the placebo group had 3 times more side effects and complications than the patients actually taking the drug. And that was, some of those were nausea, headache, dizziness, and a few other things like that. But the people, it may have been that the placebo group actually got infected with the virus.
I'll jump on it too. So we all talked about hydroxychloroquine and ivermectin last year when there were no therapies, there were no cures, there was no vaccine. We had nothing to help fight against COVID. So we all thought something's better than nothing. We needed some kind of weapon against COVID. So hydroxychloroquine has been shown not to work, and actually it's been harmful. Azithromycin hydroxychloroquine has shown to cause heart issues in patients too. Steroids have worked. Ivermectin, the studies they saw, and I was a big fan of, hopeful of ivermectin working. I really was, ask anybody. I've even prescribed it when there was nothing else to give, because the data at the time were very small studies. They weren't randomized controlled studies that were what we consider high quality studies. So at that time, we were working with what we had, with what we thought we had at least. So when we had no vaccine, we had nothing that was shown to actually be as effective as they are now against COVID. We had to work with what we were told might work. And that was ivermectin, and those are other medications too. But now we know the studies that had borne out had not been quality studies. And then the quality studies that are being done right now in England and throughout the world are showing it's not as effective in the low doses that we as humans would normally consume. So that's why there was an FDA tweet or something about you're not a horse, or don't use ivermectin. That's because ivermectin it's a medication that's been on for decades, but the amount that we've seen be beneficial in a lab study only, in a cell culture study, like English mentioned, in a laboratory, not in human, has been very high amounts of ivermectin that might actually hurt humans. So that's why
toxic.
Yeah, so we've taken a step back from ivermectin, and I was a big fan of that. I'm still waiting. I'm still kind of in that last group of people waiting for more data to come out from England. But for right now, it's not as safe as we thought it was going to be, and effective either.
All right, I don't know any final comments before we sign off? We're just about to the end of our time frame.
One more quick comment, sorry. You cannot diagnose COVID without a test, period. If we can, I'll hire that person to be my personal COVID detector. There are dogs that are sniffing out COVID at airports. Google that, it's pretty interesting. But for right now, those dogs aren't anywhere in any of our labs, so to tell if you have COVID,
there's a high quality study that needs to be done.
You need a test for COVID, guys. You definitely need to get it tested for COVID. If you have symptoms, which could be a lot of, the runny nose to a cough to a fever, and to say you don't have COVID, you need a test to rule it in or out. You really do.
Amen.
All right.
To go along with that is mask up, social distance. If you're sick, stay home. If your child is sick, do not send your child to school. And if your child was notified by the school that they should quarantine, please, I know parents have a tough time with managing kids and work and all the sorts of things going on in life, but think hard about keeping that kid home, because we are seeing a high percentage of those that are supposed to be home from close contacts getting sick with COVID. So keep that in mind, folks.
All right, we're going to have to leave it there. I want to thank you all so much. Thanks to our panel. Thank you to everyone who's participating and listening, and for all your good questions. Please watch your email for some upcoming events and invitations and other town halls. Thank you so much again for joining us.